Dr. Connie Wang today. As we know, she's one of the faculty here at UCSF, and she specializes in caring for patients with gastrointestinal motility disorders, including esophageal motility disorders, gastroparesis, GERD, as well as functional disorders. And now she's the new QI fellowship director, kind of guiding us through the QI projects and kind of revamping that curriculum for us. She earned her bachelor's from UC Berkeley, and then I think a lifetime UCSF after that, where she did her med school residency in internal medicine, gastroenterology fellowship, and then an advanced transplant hepatology fellowship here. She belongs to the American College of Gastroenterology, the AGA, and also the American Neurogastroenterology and Motility Society. And so she will tell us today about the approach to gastroparesis and cyclic vomiting syndrome, which I think is very high yield for a lot of the patients that we see, especially in clinic. So super excited. Thanks for being here.
Awesome. Thank you so much, Alejandro, for the very kind introduction. So just like Alejandro mentioned, I'm very excited to talk to you guys all today about two topics that are near and dear to me. So gastroparesis as well as cyclic vomiting syndrome. I think two entities that we don't learn as much about during fellowship, and we may not encounter as frequently. And so hopefully I will be able to give you some key learning points here throughout this talk. And feel free to, as always, put any questions in the chat box. I'll try to keep an eye on it. But we should hopefully have some time at the end as well to go over any questions. Oh, there we go. Okay, so objectives today is really to discuss the diagnosis and evaluation for gastroparesis. So kind of what are the appropriate studies to make sure to confirm that we obtain, as well as kind of briefly overview the management gastroparesis with a particular focus more on like the medical management gastroparesis, and then an overview as well of the cyclic vomiting syndrome and a subset of cyclic vomiting syndrome, including Cannabis hyperemesis syndrome as well. So just to start off, why care about gastroparesis? So we do know that the prevalence of gastroparesis has actually been increasing over time. And so here on the left side, this is a study that was done using data from the NIS and HCUP, in which that was done back in 2008. And already at that time, they kind of looked at what was the prevalence of gastroparesis patients presenting to EDs. And in 1995, there was only maybe 4,000 visits at the time, but within less than 10 years, that has well over doubled. So it's jumped up now to 11,000 visits. And you can see that specifically these are visits related to gastroparesis concerns or complaints, whereas other very common upper GI symptoms like GERD, nausea, vomiting has all remained relatively stable during that time period. So really gastroparesis has been increasing, maybe related to increased recognition, partly as for that reason. And then here, the study on the right, so this is a little bit more of a recent study from 2019. I apologize. Sorry, the study on the left was on data on looking at hospitalizations with the complaints of gastroparesis specifically. And then, sorry, the study on the right now from 2019 is looking at ED visits by year. And this is a little bit more recent data now. So looking at data from 2006 to 2013. And similarly here, we see that there's been a very sharp increase of specifically gastroparesis-related ED visits. So in 2016, a little less than 16,000, and now again has well over doubled in a short time period now in 2013, seeing up to almost 37,000 visits in the ED related to gastroparesis concerns. And so again, why might this be? So, one issue that we know is that there's not really any cure for gastroparesis. We know that this is going to be a chronic disorder that patients, have to deal and suffer with. And so it might be that we're just kind of accruing increasing number of patients over time, unfortunately, because we are not able to cure them. And second, as I mentioned, probably some increased awareness among physicians, as well as by patients who are getting diagnosed with gastroparesis. And then some other potential factors here, maybe in terms of like the etiology gastroparesis, one of the important ones is diabetes, and we know that diabetes is on the rise. It's a common trend in the US that we're seeing. And then also maybe along with that, there's increased use of maybe drug-induced gastroparesis. So with treatment of diabetes using GLP-1 agonists, which we know is a common can commonly cause like delayed gastric emptying, as well as surgeries related to that. So sleeve gastrectomies, et cetera, related to obesity may also be contributing to more surgically related gastroparesis. So here I just want to kind of highlight as well, again, that the burden and impact of gastroparesis on patients is quite significant. So several studies back in 2017, 2018 kind of looked at what is the impact on patients with gastroparesis and their quality of life. And they did find that among patients with gastroparesis, they oftentimes score much higher in terms of scores for abdominal pain. They oftentimes have lower scores for mental health disorders and social functioning. And the scores are actually similar to those of patients with other very serious chronic medical disorders or even depression. We know that just like as I mentioned in the prior slide, that there's increasing, hospitalizations and ED visits related to gastroparesis. And so not surprisingly, we're also seeing that there's increased healthcare costs among this. And so in this, one of the studies that they looked at, over 50 patients had reported at least one ED visit in the prior year, and almost 50% of patients also reported that they had been hospitalized due to gastroparesis in the prior year as well. And again, importantly, many of these patients report a reduced quality of life. This also has led to not being able to perform as well in their jobs, leading to lower annual income. And then actually 11% of patients were on disability because of the severity and significance of their gastroparesis symptoms. So we kind of touched upon this already, but what are the etiologies or causes of gastroparesis that we know of? So this is a much older study from 1998, and at that time, it was a very commonly accepted distribution that the most common cause of gastroparesis is actually idiopathic. So about 36% of patients in this study thought to be due to idiopathic. The next most common would be diabetic, about another third of patients from diabetes. And then a little less than that would be post-surgical, and then less common disorders may include neurodegenerative causes like Parkinson's disease, autoimmune disease, drug-induced, as well as others. There was a more recent study done about 2 years ago now, and they also, again, took a look at this large national database and to identify what are etiologies that are now being more quoted as terms of the cause of the gastroparesis. Interestingly here, they now find that over half of patients may be, thought that maybe the gastroparesis is due to diabetes. I think that's probably a little bit high. There was a pretty dramatic drop in the number of idiopathic patients. And just from my personal practice, at least, I still feel like I see a lot of idiopathic patients. So this might be a little bit of an understatement. But there's been a little bit of an increased trend in post-surgical as well as drug-induced causes for gastroparesis in more recent times. So also just wanted to review, what the pathophysiology behind gastroparesis. And so, to start kind of going over what is normal gastric motility to start off with. And so we know that the stomach is divided into kind of more the proximal and distal parts. And so in the proximal area, we have here the fundus, followed by the gastric body. And then in the more distal area, we have the antrum, the pylorus, which then connects to the duodenum. And so the fundus here really is considered to be a reservoir for food in the stomach. It helps with regulating the liquid emptying and plays an important role during a meal to accommodate and relax, again, to allow that food and meal to kind of sit within the stomach comfortably. It's thought that this is mediated by the fundus is mediated by inhibitory neurons in the enteric nervous system. And so you can imagine that if there's defective fundic accommodation or function, this can a symptom that could lead to could be caused by this then would be something like early satiety or that fullness sensation that patients may commonly complain about. So next we have here the gastric body. And so here we know this is where the main pacemaker for the stomach is located, as well as where the interstitial cells of Cajal kind of initiate that slow wave activity, which helps to regulate the motility of the stomach and then creates the cycle of 3 cycles per minute. And so we can get gastric dysrhythmias from this pacemaker region, and that can maybe contribute to some symptoms like nausea in particular as a result. Then we have here the antrum. And so this is kind of the more muscular part of the stomach. In this area of the stomach, this is where kind of that mixing and grinding of food takes place. And this is very important in order to break down the food into less than 2 millimeter size particle size, so to create that chyme. And this is thought to be regulated by the more excitatory neurons. And again, this is important so that that mixing grinding process is needed in order for the chyme to be able to pass through the pylorus. And this is a very muscular sphincter that, again, only allows a certain millimeter size of that particle to enter the small intestine. So if we have any hypomotility of the antrum here, this could lead to, again, symptoms of early satiety and nausea as well. So after a meal, the pylorus now has to contract to allow that grinding activity to take place in the antral area to kind of keep the food within the stomach. And again, if there's either impaired electromechanical activity of the pylorus or reduced pyloric distensibility, this again can lead to delayed gastric emptying. And then finally, there's actually a very important coordination between the antrum and the duodenum. And so we call this, again, the antral-duodenal coordination. And this leads to the emptying rate of the stomach. So similar to kind of how we think of like defecatory disorders and the pelvic floor dysfunction, these two segments of the gut have to be highly coordinated in order to regulate the rate of emptying the stomach into the intestine. So we kind of reviewed over here, there are many different mechanisms by which the stomach must function normally in order to have, an appropriate emptying of food. And so you can imagine, because there's so many different areas of the stomach that can become dysfunctional, that treatment can oftentimes be really challenging because there's not really one single target or one secret therapeutic approach that's going to work for everything. So now let's define how we diagnose gastroparesis. So really there's three key features in terms of making your diagnosis here. So first, we have to have a syndrome of cardinal symptoms. And so these include nausea and vomiting in particular. Really, when I encounter patients that don't have any report of nausea or vomiting, I'm a little bit suspicious that they may not have gastroparesis, and maybe we're dealing with something else in that area of symptoms. So really, I think of nausea and vomiting predominantly. But other common symptoms that you'll encounter are early satiety, postprandial fullness, epigastric pain. So pain is very common, probably in over 60% of patients will experience pain, as well as bloating, and less commonly, but can important to realize is also weight loss. Next, we have to have some objective measure actually confirming that there's delayed gastric emptying. And I'll go into a little bit more, I think the next slide, about how we can determine gastric emptying. And then lastly, this has to be in the absence of any mechanical obstruction. So you do have to perform some sort of test to rule out mechanical obstruction, commonly because we're gastroenterologists will do an endoscopy, but could also consider like an upper GI series with a small bowel follow through to confirm, again, the absence of any sort of gastric outlet obstruction. So again, what are some different modalities that we have in terms of how we can measure stomach emptying as part of our diagnosis for gastroparesis? And I would say really the gold standard and what we use most commonly is going to be gastric emptying scintigraphy. And so it's also very important here to make sure we have a high quality study. And what do I mean by that? Ideally, you want a gastric emptying scintigraphy study that's at least, that is 4 hours, I should say. Oftentimes I'll get referrals from patients who've only had a 2-hour study. And there, just because there is a higher risk for a false positive result there, oftentimes they'll actually just repeat the study and actually obtain the 4-hour study to really confirm, whether or not this patient truly has gastric emptying. And so what are the cutoffs? So, technically, again, at the 2-hour cutoff, you can make the diagnosis at 60% if there's 60% gastric retention activity at the 2 hours. But as I mentioned, really our gold standard is to consider at the 4-hour cutoff. And so at 4 hours, we're measuring the retained gastric activity. And if it's greater than 10% retention, then that's considered delayed gastric emptying. And then here, this is just an example photo. So oftentimes, patients ask, like, what do I have to do for the study? So I'll always warn them they have to eat these radioactive eggs. So these are eggs that have technetium. So they'll usually eat, it's actually used egg beaters, and then they'll get 2 pieces of toast with some jam, and then they also get some water to consume this meal within 10 minutes. And then again, they monitor and measure the activity in the stomach at these different time points up to 4 hours. Another option to consider is wireless motility capsule. And one of the, I guess, advantages you could say for using this device is that you can actually get a motility of the entire gut, so not just the stomach, but you also get information about motility within the small intestine as well as the colon. So in case you're concerned for kind of a pangiitis motility issue here, and it was considered retention when the stomach greater than 5 hours would be consistent with delayed gastric emptying. The only issue here now is that this is actually no longer on the market. So not currently available anymore. And also there was, some caveats that people didn't feel like this is really a truly physiologic test because you're not really consuming a food, you're consuming a capsule that's kind of non-group degradable. And so whether that really reflects, truly the gastric emptying was also a little bit of a question here. And then lastly, so this is actually not as commonly known, but this is FDA approved for actually evaluating gastric emptying. And so this is a breath test that is done with carbon-13 labeled spirulina. So this is actually available similar to kind of how a breath test is performed for SIBO testing. We have the patients consume again eggs with spirulina, and then they're asked to blow into the bags at different time points. Because of the just because it's kind of laborious, although technically you can actually do this test at home, similar to how you can do the SIBO breath test. But it's not commonly done in many clinics. So it's usually really only used in research settings at this point, but maybe something that to consider in the future. So how good is gastric emptying in evaluating, especially patients with gastroparesis in terms of correlation to symptoms? It's actually not great. So that's kind of the tricky part here, that even though we really base or hinge our diagnosis of gastroparesis on some sort of measure of gastric emptying, there's actually not really great data to show, whether impaired gastric emptying causes symptoms of gastroparesis. And so this is a study that was done, older study now, back in 2011, with the Gastroparesis Consortium, and they looked at symptom severity measured by the GCSI. So that's kind of our most commonly scoring index for gastroparesis symptoms, and compared to the gastric emptying rate down here on the x-axis. And this is kind of really about as negative a study as you can get. Really, there's no correlation between, our gastric retention and symptom severity here. So despite that, why do we still think that gastric emptying is important? And so there are some studies that have demonstrated that patients do improve with regards to their symptoms when using medications that help to speed up gastric emptying. So the caveat here, so you can see, this is a study that looked at various different prokinetic agents. So like cisapride, which we don't actually use in the US anymore, but erythromycin, domperidone, we're all familiar, metoclopramide, et cetera. So there was, some suggestion that there was some symptom improvement when there was an improvement as well in gastric emptying. However, the degree of how much improvement you saw in patient symptoms didn't necessarily correlate with the degree of improvement in gastric emptying as well. So again, I think this kind of really highlights that there's probably many factors at play as to what contributes to the development of patient symptoms related to gastroparesis. So it's really not just about a global, delay in the stomach emptying, but again, kind of thinking back about what are all the different mechanisms that go into how the stomach has to empty. So thinking about fundic accommodation, kind of antral hypomotility, dysrhythmias, even visceral hypersensitivity. There are probably many other parts as to why patients experience the symptoms they have when they have gastroparesis. I also just wanted to highlight functional dyspepsia. And this is something that is something I always think about when I'm evaluating a patient for gastroparesis. Do I also need to consider whether they may actually have functional dyspepsia? And so why is that? So kind of going through, how do we diagnose functional dyspepsia here? So it's really based on Rome 4 diagnostic criteria. And so patients need to have had at least one of the following symptoms. So similar, you can see to symptoms, the cardinal symptoms of gastroparesis, either, postprandial fullness, early satiety, gastric pain, or epigastric burning, as well as the absence of any sort of structural disease to explain the symptoms. So similarly, oftentimes they'll have a normal endoscopy. And then they have to fulfill the criteria for at least 3 months with symptoms in the preceding 3 months, and the symptoms have to have started at least 6 months before the diagnosis. And so this is a study looking at patients with functional dyspepsia who are given a meal. So here on the y-axis, we have a symptom score. The higher the score, meaning patients were more symptomatic. And again, we found that among patients with functional dyspepsia, they're kind of created these kind of two groups or two subsets of patient populations. So in patients who had symptoms that were more meal related here, you can see that patients had worsening of their symptoms, so kind of higher symptom scores within a short period of after eating a meal. So in particular, you'll notice that postprandial fullness and bloating were much higher amongst these patients. And then there's another subset of patients who really didn't have symptoms that seem to be as significantly related to meal timing. And so you'll notice that in this group of patients, oftentimes their predominant symptoms tend to be more pain, as well as fullness and bloating. And so because of this, they've developed kind of two subtypes again for functional dyspepsia. So there's this subtype that we call postprandial distress syndrome. And this is really, again, characterized by more of that postprandial fullness and early satiety related to meals. And then separately, there's another subset that we call epigastric pain syndrome, which is more characterized or highlighted by the bothersome epigastric pain and burning, may not necessarily be related to meal times as well. So why highlight, again, so why do I bring this up? This is a study that really seems to suggest maybe functional dyspepsia and gastroparesis exist on some sort of spectrum. And so here, this is another study that the Gastroparesis Consortium published more recently, just a few years ago. And again, this highlighted the overlap between these two patients, and so two groups of patients. And so what they did was that they evaluated patients kind of at the entry of their into the study, and so obtained a gastric emptying study, a baseline, and then repeated that gastric emptying study almost a year later, so 48 weeks later. And they found that at baseline here, about compared to baseline and then 48 weeks later, 42% of patients who initially had delayed gastric emptying then flipped into a normal gastric emptying category. And similarly, on the flip side, about 40%, so 37% patients who were initially diagnosed with functional dyspepsia, then they changed and flipped over into now having delayed gastric emptying at that 48-week mark. And so they're reclassified as gastroparesis. However, so even though there was this change in their gastric emptying, there wasn't actually any difference or impact on terms of their symptoms during this period. And so what does this mean? Again, I think this suggests that probably there's a lot of overlap in terms of the patients that we see who may have either functional dyspepsia and gastroparesis. Again, similarly, they both have many common symptoms of that kind of pain, satiety, and bloating, nausea, and vomiting. And so when there's this question of whether or not patients truly have delayed gastric emptying, I oftentimes just kind of treat them the same and really focus more on kind of the symptoms that predominate and kind of help target my therapy in that sense. So kind of moving forward, just wanted to now talk a little bit more about how do we manage gastroparesis. And so kind of wanted to point you towards two resources that are really helpful here. So both published in 2022. So there was the AGA that they came out with a clinical practice update in 2022. This was really based on the more kind of an expert opinion and providing kind of practical advice as to the approach for management of specifically refractory gastroparesis. And so what they considered to be refractory gastroparesis were those patients who, again, met the criteria for gastroparesis, who were already on kind of the lifestyle dietary modification changes. And despite that, were still symptomatic, as well as having been on Reglan or metoclopramide for at least 4 weeks, and despite all of that, still considered to be very symptomatic. And so those were the patients that they called refractory. And then kind of similarly, to how we think about functional dyspepsia, separated them into groups of where they kind of more predominantly complaining of nausea and vomiting versus abdominal pain and discomfort, and then kind of focus your therapies based on that. The other clinical guideline that was published by the ACG in 2022. So this also, again, looked at kind of what was available existing literature, and then kind of gave you more information in terms of how to management. And so I'll kind of go down this pathway a little bit more detail. So to start off, all patients, we always want to review is diet and lifestyle changes. And why, do we want to emphasize and start off with that? So there was this study here that was done now about 10 years ago now, that looked at a randomized control study between patients who were kind of just recommended a regular diet versus those who were recommended this small particle diet. And so what do we mean by small particle diet? Those are foods that can really be mashed up with a fork. So super, super soft, even considered to be like blenderized or pureed. And they found in this 20-week study that patients who were on the small particle diet actually experienced an improvement in many of their symptoms, including improvement in nausea, fullness, and bloating, compared to, again, this kind of more standard diet. But it didn't seem like the diet made as much of a difference or much of an impact on abdominal pain in particular. Regardless, I think this is, evidence to kind of support, again, starting off and really emphasizing patients to start off with that small particle diet. The other common, things that you'll hear about is recommending more frequent, smaller meals. So rather than eating kind of 3 large meals throughout the day, as you may typically instead trying to eat maybe 6 smaller meals throughout the day. I find that can oftentimes be really challenging for patients because a lot of the times they just don't want to eat just because they're feeling so full after a meal. They tend to eat like one large meal for the whole day, and kind of only eat once a day. So I do find that tends to be more common. But in the guidelines, this is, what we do recommend. And then again, similar in those I didn't write here, but in patients who are, had diabetes, obviously making sure that their diabetes is well controlled on a diabetic diet as well. And so what are some of the medical therapies that we have available? So kind of broke them down in terms of, again, what category or what groups of medications that you can kind of lump them together. And they can kind of target different symptoms here. So really for nausea, you'll have kind of the whole armamentarium of your various different antiemetics. I've listed just a few over here that I commonly use. But frequently I'll use ondansetron, chlorperazine, promethazine. These 3 are nice also just because they have options that are not necessarily just pill form. So, ondansetron comes in a sublingual variation, chlorperazine, promethazine both come in a suppository. So in patients who are just having really severe nausea and vomiting are not able to swallow a pill necessarily, those are good options. And obviously they all have IV forms as well. And then some of the prokinetic agents, so like metoclopramide and domperidone, actually do have some antiemetic properties as well, so can be considered on a PRN use basis for use for treatment of nausea in particular. Aprepitant, actually, I am a huge fan of. So this is a very, very potent antiemetic. It's an NK1 receptor antagonist. The biggest issue with aprepitant really is the cost and insurance coverage, and that can be quite prohibitive for many, many patients. But when you're, if and when you are able to obtain this, for patients, I find this actually to be a really effective medication. And also, again, available in inpatient setting. They do have a IV formulation as well, so it's another good option to use. So moving on to the kind of the prokinetics here. The prokinetics, again, kind of target our gastric emptying. So kind of, again, symptoms that we think might be related to that, including kind of the early satiety and fullness and nausea. So we have kind of our two medications here, metoclopramide and domperidone. These are both dopamine receptor antagonists. And then next we have our motility receptor agonists. So this are commonly erythromycin, I'd say more commonly, but technically azithromycin also is in the same category of medication. The limiting factor with erythromycin, just to be aware of, is that there's tachyphylaxis. So I find that this is really effective maybe in the inpatient setting when you can use it just for a short period, but in outpatient settings, a little bit more challenging because, again, patients experience tachyphylaxis after a period of time, and so need a drug holiday for a period before you can reuse that. Another medication that I'm a big fan of as well is prucalopride. So this is a 5-HT4 receptor antagonist. And this is a medication that has a pro-motility effect, not just in the stomach, but kind of throughout the whole GI tract. And I'll talk a little bit more about what the benefits of this medication. And then we also have, these are kind of older medications available, but these are acetylcholine receptor agonists. So pyridostigmine, bethanechol, even neostigmine. And so this is another medication, in particular pyridostigmine, I'll commonly use in patients as well for that prokinetic effect. Next, we have agents that may be medications to kind of focus more again on that fundic accommodation and kind of that symptom of early satiety and fullness after eating. So here we really have buspirone. So this is a medication I'll commonly also add in addition to maybe some of the other medications like the prokinetics or anti-nausea or antiemetics for that added effect on the fundic accommodation. And then we have our class of drugs, the neuromodulators, which I think we're all very familiar with in treating and use, for other reasons or patients, with IBS, et cetera. And again, how I select my neuromodulators is really based on what symptom in particular am I trying to treat for these patients. So if nausea is a really predominant factor, then I might lean more towards mirtazapine or olanzapine also, as well as a very effective antiemetic medication, but has a little bit more side effects. So I find this to be a little bit more limiting compared to mirtazapine. The other benefit of mirtazapine, again, is that it's oftentimes good as an appetite stimulant, as well as in patients who are losing weight, has the added side effect of weight gain. So I like it for that reason too. And then in patients who have kind of more pain predominant type of symptoms, then I might select either TCA or SSRI or SNRI even. Although there was one study specifically, it's overall quite limited in terms of studies on these medications in gastroparesis patients, but there was one study on nortriptyline. It's very small on patients with gastroparesis. They did find that in that randomized control study, there was no benefit in using nortriptyline, but I think in practice, people still use TCAs very frequently for pain, for treatment of pain in these patients, despite that. So just to highlight again a few of the medications available for gastroparesis. So at this moment, despite the fact that I listed all those other medications, there's really actually only one FDA-approved medication for gastroparesis, and this is metoclopramide, which has been around since the 1970s. So it's a little bit of a sign of how behind the times we are. Unfortunately, in terms of management of gastroparesis, how limited it is, that we haven't really been able to come up with better medications since then. But in any case, so metoclopramide is a dopamine receptor antagonist. It does cross the blood-brain barrier, which is different from domperidone. And so as a result, does have the CNS side effects. And also because of this, there is a black box warning just to be aware of. So I always counsel my patients regarding tardive dyskinesia. So because of this, it is, the FDA does recommend limiting treatment duration to only 12 weeks. But again, I have patients who have been on metoclopramide for years despite all this. And the reason why is just, and I think kind of more recent data has kind of pointed out that the risk for tardive dyskinesia overall is probably quite low. So we used to think maybe the rates of tardive dyskinesia could be as high as 1 to or even 15% of patients. But in reality, what they found in these kind of larger population studies is that it's really quite similar to maybe the risk of what is seen in the general population. So overall, quite low, 0.101% in the general population. And then those in patients who have gastroparesis who are on metoclopramide, again, for chronically, they had a similarly, I guess a 10% increase or 10-fold increase of 0.1%. So overall, still a pretty low incidence here. And again, the risk of tardive dyskinesia is increased, though, in certain patient populations. So in particular, patients who are older, who kind of have chronic comorbidities. So those are the patients I might counsel more and monitor more carefully. And then just to mention that there is also a nasal spray form of the metoclopramide that is also a good option in those patients who are not able to tolerate oral. So just to kind of touch upon prucalopride, as I mentioned, this is a medication that is a 5-HT4 agonist. And so as a result, it doesn't actually just impact motility in the stomach. It actually will, it's FDA approved for actually treatment of slow transit constipation. So really it has this kind of pro-motility effect throughout the whole GI tract. And the reason why this has been beneficial is one, many patients with gastroparesis actually also have constipation, and it's been well demonstrated that constipation will worsen their gastroparetic symptoms. And so prucalopride in this study that was done now about 5 years ago, they found that in patients who had gastroparesis, more of them had idiopathic gastroparesis, though. But in this 4-week trial period, they found that patients who were on prucalopride compared to placebo actually did have an increase or improvement in the gastric emptying, and that actually also led to a reduction in their symptoms as well as an improvement in the quality of life. So another medication I do like to consider in many patients who have constipation as well as gastroparesis. Just to briefly touch upon some of the non-pharmacologic treatments. Again, I think Dr. Kwanda after me is going to be talking a little bit more about GPO in particular, but there are a number of therapies that you can direct towards the pylorus. So again, the thought here being if there's some sort of pyloric spasm or decreased pyloric distensibility that's leading to that delay in gastric emptying, then there are a few different options here. Dilation and transpyloric stent placement has really fallen out of favor, I think, in particular now because we have the option of gastric pearl endoscopic myotomy or POP, GPOM or POP. So this has really become popular in recent years. And again, I won't talk too much about this, but something that's something to consider. Botulinum toxin injection, I'll talk a little bit more about. It's a little controversial, but I do actually use it quite a bit in my practice. And then there's also the consideration for surgical pyloroplasty. And then some other non-pharmacological therapies to consider is gastric electric stimulation or gastric pacing. This is actually has mixed data, but I would say overall does seem to have a really good benefit in patients, in particular, those who experience nausea and vomiting, and more so probably patients who have diabetes. And this is something to consider. And then there are, again, other surgical interventions like gastrojejunostomy or even gastrectomy in severe cases. So botulinum toxin injection, I just wanted to touch upon here. The reason why this has been a little controversial is in the guidelines, it's actually not, there's actually a strong recommendation to not perform Botox injections in the pylorus. And the reason why is because there were 2 very small RCTs, each less than 30 patients. And in those RCTs, they compared intrapyloric Botox injection versus sham or saline injection. And they found there was no difference in terms of the benefit between the placebo group and those who underwent the Botox injection. So because of that, in our guidelines, it's actually not recommended. But in practice, again, as I mentioned, I personally use this, and I think many other people do, actually still find Botox injection can be very beneficial. So in kind of these open label trials, more recently have demonstrated that there has been that Botox injection can have benefit in particular. So this was a study that was done now about 5 years ago that looked at in patients specifically who had, again, decreased pyloric distensibility. This was determined by EndoFlip. That those who underwent Botox injection did experience an improvement in symptoms, quality of life, as well as improvement in the gastric emptying. One other thing just to highlight is also how much Botox injection to use. So there has been some studies that demonstrated that patients who had received 200 units of Botox injection as opposed to 100 units were more likely to also experience benefit. So in my practice, I always use 200 units. Okay, so I know I'm running a little bit short on time, but I did want to actually also touch upon cyclic vomiting syndrome, because I do think this is something that we don't think about as often, but it's actually more common than we think. So what is cyclic vomiting syndrome? So this is a chronic disorder of gut-brain interaction. Again, that's being increasingly recognized. And really the characteristic feature is going to be this acute episodic nausea and vomiting. I'll go into more of this in detail. The prevalence, as I mentioned, we think is probably more common than we think. So it's anywhere from 0.5 to 1% of adults. So similar actually to what we see in terms of the prevalence for celiac disease or even inflammatory bowel disease. So not as uncommon as we think. But oftentimes, very frequently, patients have a long delay in their diagnosis. So in some studies, taking as many as 5 to even up to 9 years for patients to receive a diagnosis, just because, again, it's, I think, something that's very under-recognized. And there is overlap, again, with this cannabinoid hyperemesis syndrome, which I'll talk a little bit more later as well. So with CVS, there's a lot of comorbid conditions that can be commonly associated with CVS, just to be aware of. Very frequently in the systematic review found up to 40% of patients may have coinciding migraine, and actually treatment of the migraine is very important for also their symptoms as well as management of CVS. These patients also frequently experience irritable bowel syndrome, headaches, even a slightly increased risk for seizure disorder compared to the general population. And the thought behind this is probably there's some, again, this episodic neurologic impact that may produce both some seizures as well as CVS. And then I also just want to highlight here that patients oftentimes experience a high proportion of experience anxiety, even panic disorder, depression, and bipolar disorder compared to the general population. So again, very important in terms of treatment and management of CVS is also managing these other their mood disorders as well. So how do we diagnose CVS? Again, this is going to be based on the Rome 4 criteria. So in the preceding 3 months, all of these 3 criteria need to be met. Importantly, again, it needs to be these very stereotypical episodes of acute onset vomiting that typically lasts less than a week. So anywhere, the duration of the episodes can be a little bit variable from even just a few hours to a few days, but generally should all be less than a week. There has to be at least 3 discrete episodes within the preceding year. And at least 2 episodes in the last 6 months. And again, these episodes need to typically occur several weeks apart, but at least 1 week apart from each other. And then the in-between, so the episodic periods, there should be an absence of vomiting and nausea during this period. But I would say more commonly, there may be just milder symptoms. So they may just have some nausea, but it shouldn't be nearly as severe as when they're kind of in the throes of an episode. Some other supportive criteria is whether there's some personal or family history of migraine headaches. Again, there's that strong association. And again, needing to rule out any sort of other contributing disorders, so like metabolic, GI, structural disorders as well. In terms of the diagnosis, again, there's no confirmatory biomarker tests for CVS. And so this is really based on a clinical diagnosis, as I mentioned, using the Rome 4 criteria. But there are certainly some features that may be very suggestive. And so again, just to highlight this, when you're thinking about a patient who may have CVS, so the majority of CVS patients will experience this very classic prodromal symptom. So probably about at least over 60% of patients will be able to kind of describe this very consistent prodromal period and the symptoms may include kind of the sensation of like feeling hot, autonomic kind of dysfunction, the sense of like impending doom, etc. But usually is a very consistent picture that they're able to kind of describe each time. During the prodrome and emetic phases, there can also be this association with constitutional, cognitive, autonomic, or even motor symptoms. Abdominal pain can be present, not necessarily in all patients, but just because they experience abdominal pain doesn't necessarily rule this out. And another characteristic feature is oftentimes these episodes seem to occur in the early morning. So oftentimes patients will mention like when they wake up, they're already noticing or feeling that they may have the start of an episode. In terms of diagnostic workup, there's not much that needs to be done. I would say, commonly an upper endoscopy probably has been performed at some point just to kind of, again, rule out some sort of mechanical obstruction. Oftentimes they have some sort of abdominal imaging, but really key here is avoiding any unnecessary or at least repeated testing. And again, highlighting this is mainly a clinical diagnosis. So what about gastric emptying? So there was a study here that looked at, what's the gastric emptying pattern in CVS, and I think this can actually be quite confusing. So in this study, actually, almost 60% of patients had rapid gastric emptying, and then about a quarter of patients had normal. It was really just a minority of patients who had delayed emptying, so 14% of patients, but these patients also might have had other explanations, including the patients who had diabetes, they're on opiates, or also using cannabis, all of which can delay gastric emptying. And the thought is that, again, more commonly was rapid emptying that was seen in these patients, and that maybe that's a sign of autonomic dysfunction that may, again, predispose these patients to CVS. So I bring this up mainly because, again, I don't order gastric emptying studies routinely in this patient population, just because it can sometimes kind of confuse the picture. So just to go over the phases of CVS, because really highlighting, again, this is kind of really important for both diagnosis as well as treatment. So you oftentimes, again, have this prodromal phase here that, as mentioned, many patients experience. Symptoms may include kind of that sense of doom or panic. Oftentimes people report fatigue, again, nausea, abdominal pain. Usually this period can last about 30 to 90 minutes. And the reason why this is so important is because this is really the window when you want to target your abortive therapies, which I'll go into more detail. But similar to how we think of like for migraines, and you want to provide patients with abortive treatments to kind of hopefully, reduce the risk of them progressing into the emetic phase. That is your kind of key period to have the patients kind of try all their different abortive medications in that short time span. Next, if unsuccessful, this will progress into your emetic phase. And this is really characterized by really severe kind of intractable nausea and vomiting. And during this phase, it's really just in terms of treatment, supportive care. So sometimes patients may need to present to the ED. They're not able to kind of keep down any of the medications orally, or also may keep up with their hydration or nutritional needs. So may need to go to the ED for IV therapy. And then following this is the recovery phase. So oftentimes this is when patients are kind of resting, kind of rehydrating, and again, getting back into their nutrition, hopefully returning back to the normal routine. And then subsequently, we have these inter-episodic or symptom-free phases in between. The goal here is really, in terms of treatment, focusing on lifestyle measures. And it's thought that this can really reduce the triggers that might predispose people to developing one of their CVS episodes. So common triggers might be, oftentimes there's some sort of stress event, and this can include both negative stressors, such as, the loss of a loved one, undergoing some sort of deadline at work or in school, as well as positive stressors, which might include like holidays, vacations, and birthdays. Those can all might be potential triggers to kind of review and discuss with patients. So this is from a recent guideline that was published in AJG in 2023, again, kind of going over the general approach to management for CVS. And really just to highlight here is kind of determining or classifying patients into the mild versus their moderate severe disease. And this is, so for the mild, it's going to be patients who have less than 4 episodes within a year. The episodes tend to be shorter, so usually just a day. And these patients typically have not had to go to the ED or be hospitalized because of their symptoms. Those who are more moderate to severe, so again, having more than 4 episodes within a year, oftentimes the episodes may be longer, so lasting several days up to a week, and that these patients may even need to go to the ED or hospital in order to receive further treatment. And the reason why this is an important distinction factor is that those who have more mild disease, oftentimes we can just treat with abortive therapies. So during that prodromal phase, really again highlighting abortive therapies, whereas those who are in the more moderate severe, then you want to make sure you're giving them the abortive therapies, but also offering some sort of prophylactic treatment. So what are the abortive therapy options for CVS? Really, again, similar to migraines, it's going to be the use of triptans. So sumatriptan is the one I'll prescribe most commonly. And the reason why is it comes in an intranasal form. You just want to make sure when you're telling patients or educating them on how to use it correctly is that you want to make sure they're leaning forward before they're kind of spraying the medication intranasally. So it can be used twice, first once, and then if unsuccessful, can be used a second time after 2 hours. And then what I'll also tell my patients is, so use your abortive therapy with a sumatriptan, but at the same time, also use some sort of antiemetic agent. And that can be, any one of their choice, like a dancertan, which can come in a sublingual form, as I mentioned, promethazine, which has a suppository, or even a prepitant, again, which is really potent and has good data to support its use. In terms of prophylactic therapies, these are a few that are listed. The ones that really are considered first line are the tricyclic antidepressants. So really amitriptyline is the best data, but other alternative ones that can be considered include anticonvulsants like topiramate, again, the NK1 receptor antagonists like prepitant, and even these mitochondrial supplements like coenzyme Q10 and L-carnitine. So just for the sake of time, I'm going to pass through the data for this. And then just wanted to, again, touch upon cannabis hyperemesis syndrome. The reason, so this is considered potentially a subset within cyclic vomiting syndrome. And, we do know that there's increasing use of cannabis kind of globally as well as within the US. And so not surprisingly, there's been an increasing prevalence of CHS that's being seen kind of nationally. But can be really challenging to distinguish from CVS. And the reason why is, so in the diagnosis, the criteria for CHS is that they have to meet criteria for CVS, meaning they have these characteristic stereotypical episodes, episodic vomiting. So they have to meet the clinical criteria for CVS. But in addition to that, there has to be a preceding history of chronic cannabis use. And what do we mean by chronic and heavy? This means usually duration of over a year and pretty frequent use, usually more than 4 times within a week, but more often than not, I would say it's often daily usage of the sustained use of cannabis. And then it's a little bit hard, but part of the diagnostic criteria is also by stopping cannabis, that actually leads to resolution or improvement in the patient's symptoms, which again is a little bit of a hard thing to do here. Some other supporting features are, you'll classically think of, patients who notice that with hot water bathing or showers, that provides some sort of transient relief. But just want to highlight, this is not pathognomonic. Actually, 50% of patients who have CVS, cyclic vomiting syndrome, and not necessarily cannabis hyperemesis syndrome, also experience relief with hot water bathing. So just to be aware of that. And then again, exclusion of other etiologies. And lastly, in terms of treatment, in short term, topical capsaicin actually has some data to support its use. And so this can be applied kind of in the periumbilical area every 4 hours as needed. This can lead to some improvement in their symptoms, but similarly to the therapies that we have for CVS can also be used for cannabis hyperemesis syndrome. So the antiemetics, medications. And then in long-term management, it's really the key here is cessation of cannabis use is necessary in order to lead to sustained relief. But it doesn't mean, that's the only, that I only counsel patients to stop cannabis use. I oftentimes will also prescribe a tricyclic antidepressant. So similar to how this is effective for patients with CVS, this can also be effective in patients who have cannabis hyperemesis syndrome, especially during that period when they're trying to titrate or wean off of the cannabis. That can be particularly helpful. Okay. So just some final take-home points here to wrap up. So again, reviewing that gastroparesis, the diagnosis is really based on symptoms as well as some sort of objective evidence of delay in the absence of a mechanical obstruction. Trying to think about, gastroparesis and functional dyspepsia existing on a spectrum. And then in terms of, again, when we're thinking of management as a result of that, kind of maybe potentially treating for both. And then when we're selecting a therapy for gastroparesis or functional dyspepsia, really focusing on what is the most bothersome symptom for the patient and trying to target a therapy based on the pathophysiology that would be helpful for that. And then lastly, recognizing some increasingly common vomiting syndromes of the cyclic vomiting syndrome, cannabis hyperemesis syndrome.